All right, good morning, everyone. So just quick housekeeping before we begin. Hopefully everyone online can see the slides that are being shared. Because this is a hybrid meeting, we do have mics in the room. So just want to remind everyone, if you are speaking, to grab a mic so that those who are online can hear us. And then before you speak, also to just quickly introduce yourself, your name and affiliation, that would be great. So I will now hand it over to Sue.
Thank you very much, and good morning, everyone. What a beautiful day it is here in Uppsala. For those of you who are online, it's a beautiful sunny day after a couple of days of rain and being overcast. So we're delighted to have this double-backed Connect session, so split into two halves, about influencing EPR and LIMS suppliers to adopt FHIR as part of this first part. And then the second part will focus more around the alignment with GA4GH standards and different other products. And where we're trying to get to is how could we work collectively and in a concordat with suppliers to ensure that individual institutions aren't having to have individual conversations when at a nation level we're all trying to achieve something quite similar. And so this morning, this first part is going to really introduce again the data and digital developments as part of the NHS Genomic Medicine Service and how they link with the broader developments in the NHS. And I think our whole aim is how do we share data, not just within our country to drive, better patient care, better patient outcomes, but how do we drive data sharing across borders, especially again to improve the outcomes for patients. We've just had the arrival of a number of people into the room. In case you wondered, those of you online, why I was hesitating in my introduction, but that's what we're going to do, and we're going to talk through the work that we're doing with a range of industry partners, but also talk through some of both the challenges but also the opportunities. And I think that's really important if we think about this. And as we move through the course of the two sessions this morning, we'll do this through the lens of some case studies. So I'm going to hand over now to the team, and you can see, and I just want to go through in terms of introducing the team who are going to be speaking to you this morning. So Debbie Porter here is a Deputy Director in the NHS England Genomics Unit and Genomics Programme with a remit for transformation, and that includes data and digital transformation. We're working very closely with Genomics England, and I'm delighted that Graham Ritchie is here, and he's a solution architect. So it's quite interesting to hear the term architect when we're talking about data and digital infrastructure. And it's important we do have those people who look at what we're actually trying to create and design it appropriately. And then from NHS England as well, we have Omar Khan, who sits within the overall digital and data team for the whole of the NHS. And he's another architect, this time on interoperability standards and in enterprise architecture. So I hope you feel you've got the right people in the room it's definitely not me. I'm not an expert in data and digital developments, but I'm just going to sort of facilitate and help sort of bring the discussion together today. Those of you online, we've been joined by other people. When they ask questions, I'll ask them to introduce themselves, and so that everybody knows who everyone is. So I'm going to hand to Debbie, who's going to start.
Thank you, Sue, and good morning, everybody. So today, we are going to do a little bit of a reprise of what was presented at the National Initiatives Forum yesterday, to give you a little bit of a context around which you can hang all of the developments that we are working on, and give you an understanding of where England is as a health system in terms of developing both data and digital architecture and infrastructure, and the importance with which genomics is held across the NHS, across the National Health Service. I'm going to start then with a big ambition, but it's an ambition that's reflected in the 10-year plan. So the NHS has just published the 10-year plan. It's called Fit for the Future. It's that top icon there. And you can see both on that 10-year plan icon of the front cover and the life sciences, there's a double helix. That's how important genomics is to the future of the NHS and to the life sciences sector in the UK. And that ambition is by 2035, we anticipate that genomics will be a part or influencing up to 50% of all healthcare episodes or interactions. A lot of that will be pharmacogenomics, but it's quite a significant number of interactions considering we've got 57 million population in England alone. This graphic is a representation of the ambition, the 10-year vision of the NHS digital infrastructure as a whole. I'm going to stand up because it's easier to point it out. So for those online, if you follow the little bridge from the GP surgery here, you can see a tech icon there. We've got genomics as part of the data and digital vision and the overall technical aspirations of the NHS. That's just an amusing anecdote to show that actually genomics does feature largely in the 10-year plan for a good reason. And it's the data and digital space where the growth is, we're focusing on the growth today. So that's actually not come through properly. Right, so the 10-year plan, data and digital technology, that should say single patient record. And it should say, yeah, exactly, thank you. I can't read that, I haven't got glasses on. Tiny little one. So we will refresh that when we share these slides with you. But essentially, the single patient record was a commitment made in the 10-year plan. The single patient record is a commitment made by our Secretary of State for Health. So it's come from the highest level in the health sector. Thank you. Under that single patient record, and within something we've called the 5 big bets, there is a unified genomic record, and that integrates patient data with relevant clinical and diagnostic data in near real time. So that unified genomic record will be, at the very minimum, a feed into that single patient record. The likelihood is, because we are 2 years down the line into discovery and alpha phase with the UGR, the likelihood is that we will be one of the pilots for the structure, the architecture of that single patient record. Still, conversation's still ongoing, but we think that there's a strong possibility that that could be the case. But as I say, as a very minimum, the genomics UGR will feed into the single patient record. The other commitment that I wanted to highlight was the expansion of the UK's research data sets. So this is not just about the clinical infrastructure. This is not about direct care on its own. This is about a single data set and a single data flow, or many data flows, that will support both research and direct care, as well as other aspects. But those, just to be clear, are commitments, formal commitments in the UK government's life sciences sector plan and in England's NHS 10-year health plan. Oh, there you go. It's a build. So just to go into a little bit more detail about the single patient record. Now, Wes Streeting is the Secretary of State for Health. We need to work together to create a single patient record owned by the patient, shared across the system, so that every part of the NHS has a full picture of the patient. Now, it goes a little bit further for the Unified Genomic Record, because it's not about a snapshot of that patient. It's about a longitudinal record. It's about reanalyzing. It's about re-referring to genomic data that's already been taken, and it's about having an up-to-date version of the truth, a real events-based, architecture-driven record that is up to date and comprehensive and universally accessible across the NHS. So the core vision for the single patient record is to give patients visibility, and we do that through the NHS app. And we've got wireframes set up from the Unified Genomic Record to show how that data is going to surface in the NHS app and how patients will receive sections, distillations of their genomic data, so essentially their diagnostic results. And then that NHS app will also be used to share preferences as well. So share preferences about how they connect to their other family members' data. And that needs to be reciprocal. So a two-way consent to share records across family linkages. It will have an audit of who's viewed their record and for what purpose. And it will also allow them to update their research consent status. It doesn't say here, but it will. That single patient record is a single version of the truth. So it needs to be comprehensive and up to date. And it will allow patients, healthcare professionals, even social care, because our NHS is expanding its remit into community and neighbourhood teams. And it will allow interactions as well as autonomously prompt actions to occur. So flag if somebody is going to make a prescription choice for a patient, to say that this patient has had a pharmacogenomic test result and may be relevant to the decision that is about to be made by the prescriber. It will enable secure data access for third-party applications for research and clinical trials using something called purpose-based access control. And then we move into the Health Data Research Service. This is a nascent service. It will provide timely access and a single point of entry to the UK's breadth of general practice, hospital episodes, prescribing, dispensing, death registration, whole population data, and it will be standardized to enable AI growth and usage. It will link pathology, radiology, and genomic data. So it's not just about genomics. It is about a whole landscape of connected and relevant data, clinical data. So we are uniting genomic, diagnostic, and clinical data at a population level. And those who are in the room and listened to Sue at the NIF yesterday will understand that the NHS Genomic Medicine Service is moving into population health. So moving from currently, we sit in sort of the research, the rare disease and the cancer space. We are now moving much more into the population level healthcare, so preventative purposes. And we are potentially acting as a magnet for investment from pharma, for drug discovery, for AI development, and any other global trials. We are removing the barrier for science and research by improving accessibility and quality of data. And the aim is to increase the number of data-enabled research projects. This is what the clinical service looks like roughly. We've got 7 regions, 7 geographies, all part of the Genomics Medicine Service. Those laboratory hubs are supported by a number of other laboratories who do some level of testing, but a lower level than the hubs. And they do the interpretation and reporting. So many of them are dry labs. And we're also supported by 17 clinical genetic services, not currently part of the Genomics Medicine Service, but the anticipation is that those clinical genetic services will be brought into the GMS as a whole. And you can see the scale of the population there, nearly 5 million in the southwest now and up to 11 in central and south. So that population has grown significantly since this slide was created. The purpose of the day here is interoperability. That's the name of the game. We have got currently 189 secondary healthcare trusts who have an electronic patient record. We have more than 6,400 GPs, practices that have a vast number of different systems. So 120 plus suppliers, 160 plus products, and 50 plus EPR integrators. The landscape is complex. Getting EPR providers and LIMS providers to adopt a single interoperability standard, we think, is the only way to connect the parts of this system. We believe global standardization is the key for accelerating biomedical advances, enabling sharing, responsible sharing, and interoperability of genomic data across institutional boundaries and across borders. We think this reality requires a global health service to align on standards. So what we are hoping to do today is to understand what the landscape is in your countries, understand whether there is a drive towards signing something, as Sue mentioned, like a Concordat, so that we can persuade EPR and LIMS providers to adopt FHIR standards, so that we can actually move genomic data around in a very structured way. We have got a piece of legislation that's come through this summer in the UK. It's called the Data Use and Access Bill. That will force suppliers to adopt standards. It's going to take at least 2 years, we think, to operationalize this. So we're trying to attack it from a number of different angles. And the power in this community is having one voice. And if we can all agree on one voice, then that will, I think, persuade EPR providers that actually they need to adopt these standards prior to them being forced to adopt them in the UK and abroad as well. Yes, sure. So things like, our electronic patient records, we have got a number of very big suppliers. So Epic, Cerner, those are the Meditech, those are the big players in our market. However, we have got a myriad of other suppliers and other products, but every single one of them, every single provider in our organization has a bespoke version of Epic or Cerner, whatever. So for example, we have GOSH, the Great Ormond Street Hospital, across the road from another Epic provider. They can't communicate between the two of them because they've got 2 very separate instances of Epic. So it is a very, very difficult, complex landscape.
Hello. I think I'll be talking a lot today. It's not true that they can't talk to each other, right? Epic actually for genomic data uses very similar data structures no matter what version of Epic you're on. It may be that there's some IT work that has to be done to get them to talk to each other.
Yeah, there certainly is. They have Epic has 14, I think, at the moment, just about to grow, providers in the UK. Our system wants to use a requester user from any trust in the UK. So we've got 240 odd trusts, not all of them with an electronic patient record, but we've got 240 odd trusts that we want to enable to communicate with our laboratory systems. We want to enable them to communicate with our pathology systems. And therefore, connecting Epic to Epic is not necessarily too much of a problem, but connecting Epic to Cerner and Cerner to Meditech through what we're trying to do is a single broker that everybody communicates in the same language.
Yeah, don't mean to push this, but it's really useful for us to understand the baseline and how it works, but also how that then integrates in the one NHS app to rule them all at the current time. Because it's, I think in many of our systems, we face this lack of connectivity and all flowers blooming. So how disconnected it is.
I mean, there's no link at the moment with the NHS app. That's part of what we've got to do. And I think in terms of a priority, it's how do we get systems, different systems, EPR systems, to talk to one another and to talk to the central system that we're building. And then as part of that, to adopt the standards. But in doing this, then working with the NHS app team to ensure that they'll be able to pull through the data into what the patients will be able to, or families will be able to view. And I think there's still quite a lot of work to be done on that, Catherine, in terms of what would be on the NHS app.
So that would be the patient interface.
That's the patient.
Would it be the primary care interface as well?
No, the primary care interface will be via the Unified Genomic Record. So I think you're going to come on to that.
I've got some architecture diagrams.
The Unified Genomic Record would apply in primary, and we don't know what our neighbourhood health teams will use as their EPR systems at the moment, whether they'll come to access primary and community care suppliers. I suspect that's what they will do, but it will go across acute sector hospitals, tertiary specialist hospitals like children's hospitals, etc.
I'm not interrupting too much, but just one other thing I wanted to ask is currently the genomic information sort of all held in one place, and can the hospitals communicate genomic information or the different areas?
Not currently. So other than the whole genome sequencing service, which is centralized through Genomics England.
So I think that I just talk through. Can you just go back to your slide, and maybe this might help, the one about the system, you know, the GMS side. Essentially, there are, let's for argument's sake here, say there are 7 genomic laboratory hubs who are generating the laboratory data. So that will be next generation sequencing data. That could be up to the level of whole exome, especially in rare disease. And in at least 2 of our services from 3 of our services from next year, it will include rapid whole genome sequencing. That data is all stored within those individual hub laboratories. The only data that is stored nationally is in the centralized sequencing for service, which is delivered in conjunction with Genomics England. At the moment, though, there is just 1 copy of that genomic data generated, and that data sits in the trusted research environment at Genomics England. Individual clinicians or laboratory staff in our 7 GLHs cannot access that data without going through an access request. And at the moment, we haven't even found a mechanism to be able to do that. What's further complicated and why Debbie put this up is all those NHS trusts in that column on in the middle there, those are people who are requesting testing, you know, across rare disease, cancer, etc. And they are receiving a report back from the genomic laboratory hubs. And so what we're trying to do in this system is to make it work at the ground level, because we have a lot of criticism from cancer, from oncologists and others managing cancer care cases, that they can't see where their sample is and where they are. So they, in terms of the clinical decision making they need to make. So in terms of our solutions, we're looking at all the providers in the system and then saying what is it they actually need to do. But at the moment, most of the genomic data sits isolated in 7 genomic hubs. Even if they have a secondary lab associated with them, it would sit in that lab rather than in the hub lab. But they have worked out a way of being able to do more remote interpretation and analysis. So that gives you, I think, a bit more of the anatomy and physiology of the system. And primary care systems, we've tested what we need to do with them because of some of our pharmacogenomic pilots. So how do we work with those EPR systems that work there? But it's complicated, not just because there's EPRs, but there's LIMS systems as well, that are the mechanism for capturing the sample and some of the data. And so the data, the metadata for sequencing and the HPO terms creates obviously another set of challenges.
And there's firewalls between the different trusts or genomic sites?
Currently, yes.
And the only reason I ask is it's sort of similar to what we're based in Australia, so it's
I think it's probably
very
similar
Yeah.
to many different countries, and I think that's why we were very keen to have this conversation.
If I could ask, the question is framed as how do we add the genomic record into this whole connection of interop? Is there any other information that currently flows sort of back down into these systems from central to back down, or would this be the first test of that pathway?
As I said, this is a single patient record pathfinder. So that's what we're trying to do. Currently, there are small groups of trusts that are on a single system, but that's a very small geography.
So if I'm hearing it right, the challenge is not just, oh, we want to add a new field into a happy flow. We want to create a happy flow exercised with this new field.
Absolutely. And I'll show you how we're creating the happy flow. Okay. So there are 4 big projects currently running. We have a large ambition, which has got about 16 different work streams on it, but these are the big 4. Digitizing the test directory, which we heard about yesterday. So the test directory currently is an Excel spreadsheet, flat file on a web page. We have developed a common data model. We have got everything is structured, searchable formats, including fuzzy matching. So that private beta went live on Monday. Unified Genomic Record is the nirvana. That's where we're heading towards. As I mentioned earlier, it's going to be part of the single patient record. Digitized order management is the plumbing. So that's how we're stitching it all together. So that digitized order management is the development of a central broker, which is an events-based management system, and it'll be a request and return system in the center that will allow us to pass data between those different parts of the system.
And maybe just to give people dates, so the digitized test directory has to be ready by April 26, as does the order management, although that might be, you know, I'm pushing Debbie for April 26. And I think they're trying their best to get there. The Unified Genomic Record, there was a commitment in the 10-year plan. This would be delivered in 2028. So, you know, even though we're the back end now of 25, it's still a challenge to get that functional by 2028. Hence the, you know, the conversation today, just so people understand the timeline context for this.
Thanks, Sue. And then all of that is underpinned by common standards, ideally GA4GH standards, and we have signed up to HL7 FHIR as an NHS system, not just the genomics part of it. All underpinned by a solid legal basis. And as I mentioned yesterday, there is ministerial direction, which is our precursor to legislative change going through at the moment. So this is the architecture. This is what you potentially want to talk about. The digital test directory in green there is the, as I've mentioned, that's the reference data set. It's uplifting the current test directory, refactoring it slightly to include alignment with WHO, so the WHO Blue Books for cancer, for example. It's going to be machine readable, updatable via an API so that systems can draw down the latest version of it. It will also have version control, and you will be able to interrogate what was available at a particular time when you wanted, when your patient was tested previously, for example. You will know what targets were available on that test directory at that time. It provides the test reference data set for order management, and that's the broker in the center there, and I'll go on to that in a second. It has introduced this whole data common data model, which is expandable and scalable to add things like panel app and other things as it expands into the future. It's being built on the federated data platform, which is the data management system of the NHS. This is order management. So essentially, it's two elements of it, or three elements really. It's the central broker, so the system that receives and sends out the messaging. It does have an access via a portal, but ideally what we want is for individual systems to talk directly to the broker, so to be interoperable. That's the nirvana. We do have proof of concepts that have been done and alphas that have been done through ties. And this is where EPIC has been really helpful in linking GOSH and the Royal Marsden to the broker. And we have been able to talk to a Cerner instance of EPR through the broker, through the alpha broker. So we have proven the fact that we can message the system. They have done it through trust integration engines rather than direct interoperability. So we're advocating the interoperability because if we change it once, then we can avoid doing expensive and protracted integrations. So that consumes the DGTS reference data set. And I call it DGTS because it is a service and it will grow, but it is the basis of the test directory, and then it will grow to consume things like the panel app, etc. And it will interact with the Unified Genomic Record at the bottom there to persist order data sets. We recognize that not everybody is going to be digitally mature enough to interoperate or integrate with the core broker. So there is an order management portal that has been developed as well. So people can go onto a website and put the same information in, but they will just be sending it via, instead of natively from within their own EPR, which is what most clinicians want, they will have to go onto a separate website to be able to do it. But it does get over paper, transcribing errors, and a whole host of issues that are associated with currently placing an order for a genomic test. Sorry.
I see a lot of two-way arrows here. And I think, I just want to know, where are we pushing information? Where are we pulling information? I think that those That's the meat and potatoes of this.
I guess. Yeah, I mean, we'll get into maybe a bit more in the next few slides, but essentially for the central broker, we're looking for applications or ordering systems to push information such as that test order request into the broker. That then gets pushed out to lab systems so that they can actually process that order. Or and we also support querying mechanisms to actually find historic test orders and things like that. And then similarly on the reporting side, have the report sent into the broker and that get then pushed out to the EPR systems.
Okay, so the idea is that the broker will know where the information has to go.
Exactly, yeah.
And source of truth
The single source of truth.
for things like the orders and the
Yeah,
reports.
that will be the single source of truth. It's the broker.
So the broker is also a repository.
Yes.
Okay.
Yeah, for metadata.
There's other stuff too, but that's one.
Okay. The only potentially anticipated pull requirements is for things like pharmacogenomic results. So there will be a flag to say it's available, but the GP or the prescriber will have to pull the data in. That's currently what we're discussing, but it's still under development.
May not be where we go. We may look for a different solution on that.
Yeah, I think this, this is challenging because, typically orders and results have been transactional, right? Versus having this system with the central broker and having to constantly ping and check for updates.
So it will not ping. It will automatically tell you when there's an update. It will be available as an update, but it's only the system with the pharmacogenomic results that we're saying you potentially have to query and then have a response. Okay, Unified Genomic Record then, the bottom section here in green, which is essentially what we're trying to build. It spans the direct care population management information. It will be supported by this FHIR record. It will also point to the genomic data stores where the genomic data will be held. And it will point to the clinical repositories where other data will be held once we have those links. It will provide the persistent data storage for order management. It will it will do everything that the single patient record needs it to do. We've got through an alpha phase. We've got a proof of concept working with the NHS app and with the national record system. We are anticipating it feeding wider MI platforms like the federated data platform to use it as a management information tool, clinical trials matching service, and Graham will go into that in more detail tomorrow. And it will link to EHRs and LIMS systems. Crucially, these are the fundamental elements of it. So federated object store, you heard there were 7 Genomics Medicine Service regions. Each of those regions currently has their own data store. Those data stores will be federated in the future. And alongside the Genomics England federated data store. So there will be an ecosystem of 8, let's say potentially S3 buckets currently, with cross permissions to, depending on purpose-based access control, to have a full data set. Using GA4GH standards to query and potentially, if Graham gets his way tomorrow, to write DRS to those stores. That central FHIR store is the one ring that rules them, one ring that binds them. And it's a HL7 R4 API. It will contain a small set of metadata, not significant size of storage, but it will contain all of the transactions for order management, as well as the simple diagnostic reports, patient details, whether they are linked to their family members, whether they've given permission to link to their family members, they'll hold their research status, whether they have volunteered for research and consented to do so. And it will say the time and the place and the type of diagnostic that was undertaken. And then on the right-hand side there, that bulk query interface, we're still a little bit more in development on that, but FHIR resource tables and variant tables inside that bulk query interface to enable things like cohort identification for particular parts of the genome or for particular phenotypes, etc. So the project's now in sprint 10 of its alpha phase. We have got a strong proof of concept, and it should be completed at the end of this month.
Is all of this identified data, patient keyed, patient identifier?
Yeah, so the FHIR store holds the patient identifier, the NHS number, and then it gets pseudonymized into all of the different queries if there's a research query.
I will go into some more detail on this bit in the next session. This one, but basically, we have got a prototype Beacon API, and that does the Beacon thing. So you can ask for data at different levels of granularity. It is held fundamentally, so it's patient identifiable, but it's possible to present a pseudonymized view on it, and quite how we control access to which level of information is something we still need to figure out. We have some plans and thoughts, but it's not yet complete.
We've done the technical bit in outline, but we've still got to do the governance bit. Okay, so we've developed this on the back of 4 use cases. So pharmacogenomic guiding, and Sue mentioned the Progress trial, Progress RX in the Northwest has been developed with 20 GP surgeries, generating a pharmacogenomic profile and pushing that pharmacogenomic report to some GPs or them pulling it. So that's the trial that's undertaken there. Clinical geneticists can see their patients. Clinical trial investigators can identify cohorts, find eligible patients, and patients can look for their data on the NHS app. So we've seen that one. Future vision. Current mode of operation, a lot of paper-based testing, lots of challenges in how genomic tests are ordered, lots of duplication in process, lots of transcribing, lots of opportunity for making errors, and it is inefficient. It is also not scalable. So the anticipation that genomics will be involved in 50% of all healthcare interactions by 2035 is not possible on the current system. So in order to scale it, we are moving towards the future mode of operation with that national broker and feeding that unified genomic record in the future. And now I'm going to hand over to Omar, who is going to talk a little bit more about the FHIR standard development.
Thank you. So here, when we're talking about FHIR, it's really that interface between genomics and clinical care settings. So trying to bring genomic information and the inferences from that into a more actionable form for the clinician to actually take forward in terms of patient care. So really, if it's not very visible on this slide, but the what we're looking at in terms of FHIR is that first couple of boxes, which are the test ordering process itself and sending that information into getting that information into lab systems, and the reporting process at the end, so getting those reports back out in structured formats, because at the moment we are very much paper-based within genomics. And so there are a number of areas of investigation in terms of what standards were appropriate for these kind of areas. First was looking at how to standardize the test order data itself. We've got a bunch of templates that are used within the UK, all different between different regions. How to manage workflows and orders themselves. How we do structured reporting, specifically for genomic reports. We've got guidance already for pathology, but nothing really in the UK for genomic reports. And Graham's going to be talking later about how we do genomic data file management and how we can support discovery and querying of genomic data files. How we link family members across testing, so for cascade testing and duo trio testing, and how we get that information into unified genomic reports and represent test directory metadata in a standardized format. And as part of this whole discovery, there were a number of scenarios we needed to support. So both whole genome and non-whole genome testing for rare disease and cancer, reanalysis and reinterpretation pathways, so where you don't actually have a sample that's associated with your test order, or you're reusing data that may be stored somewhere else, and fetal testing, where your patient actually isn't a patient in the real sense in terms of a record in the EPR, and dual-trio testing, where you've got multiple participants as part of one request. So within the UK, the genomics unit came out with a quite complex national genomic testing process through elaboration with all of the GLHs within the UK, or within England, I should say, that set out the main stages of processing of a test order from that request to the final report, going from, for example, sample preparation and processing through to running a bioanalysis pipeline through to interpretation and reporting. And they also came out with a master data set that amalgamated all of the information across all of our test order forms. So that went into a bit of discovery, and so we settled on the FHIR workflow broker approach in terms of how we wanted to manage test orders, where a placer, in this case, for example, your EHR system, posts a request into a central broker. It then spins up a set of tasks associated with the national genomic testing process, each of the main stages. These are then assigned to each of the filler systems. So you could have one, the processing of or QC of the test request itself assigned to your home GLH, the sample prep and processing assigned to your wet lab, and interpretation, for example, assigned to GEL if it's in whole genome sequencing. And they can then report statuses back to the central broker so that the requesting clinician always has visibility of what's going on with your test order as it goes through the process, because as we know, genomic testing can take a bit more time than your standard pathology test. Once it's complete, that report is also then visible to the placer, and also visible to any other interested parties within that space. So, for example, your GP system, who's responsible for the care of that patient as well. Now, in terms of alignment with other standards in the space, obviously, within the UK, we follow the UK core for FHIR. So we based all of our FHIR profiles on that. In terms of what kind of interactions we needed to support between the lab system and the placer, we looked at IHE PALM, Pathology and Laboratory Medicine, and also needed to align with our pathology FHIR implementation. So that's another program that already in progress within NHS England. We also have an NHS digital or NHS data model and dictionary, which sets out the kind of logical models for certain concepts within healthcare within the UK, and the Professional Record Standards Body, or PRSB, which sets out headings for certain types of data within the UK. And for us, the most relevant ones will information standards around paternity data sets, for example. Moving on to the right-hand side, in terms of reports, we needed to support HL7 EU lab reporting guidance so that we could then share information across the EU. In terms of actual structured reporting, our gold standard was the HL7 Clinical Genomics Working Group Genomics Reporting Implementation Guide. So they set out quite usefully what sections within a report needed to be aligned to certain section or certain resources within FHIR. So that provided the skeleton for the report. And then in terms of actually populating it with information that's useful to a clinician or makes a report actionable, we used guidance from associations such as ACGS, or the Association for Clinical Genomic Science, which sets out a report should include an interpretation, should include these sections, for example. We also map to open-air archetypes in terms of the pharmacogenomic test result and variant detail archetypes to ensure that anyone who's using open-air archetypes for genomic data can also map those across. I'll touch on GA4GH standards more in the next session, but we're also looking at the overlap between FHIR and GA4GH for certain areas. So, for example, DRS and htsget for accessing genomic data files and calling specific sequences. VRS or VERSE for representation of the actual variants, and Pedigree and Phenopackets for that initial kind of order information. Now, a lot of our labs are also storing information in OMOP, and so to ensure that we get we're able to import this historical information, we needed to provide maps from OMOP into FHIR. And NHS England, or NHS England Digital, has a number of existing national services that support other use cases within the NHS. So we've got a personal demographic service, which serves our national patient identifiers. We've got the SDS, or spine directory service, which serves our national practitioner identifiers, and ODS, or organization data service, which serves our national organization identifiers. And so we needed to link all of these across to ensure that we could unambiguously identify the patient, the requester, and the organizations that we needed to send this information to. And linking back to the PGX kind of aspects that Debbie was talking about, we supported the Progress RX project with CDS hooks implementation. So they could on-demand query genomic information when making during a prescribing event to ensure that there were no contraindications, for example. So that's just a bit of background about what I've talked about.
I'm going to railroad you.
Yeah.
I don't see HL7 V2, but I see it on the next slide. So.
Yes. So for anyone who's kind of familiar with the order comm space, we understand that HL7 V2 is prevalent, at least in the UK, in terms of kind of requesting and reporting. So the question we might get is, why haven't you implemented? Yeah. Doesn't like that slide. There we go. Okay. So why didn't you just use V2? And so there were a number of reasons behind this. Firstly was because unlike your standard pathology test, you may not have all of the information needed at the point of requesting in order to fully interpret a genomic request. So, for example, you may not have all the clinical information about the patient. You may not have consent from family members to kind of add them to that request, but you still want that sample to be processed before in a timely manner. So we wanted to support. If you're doing it within V2. Typically, you'd send in your request. You'd have to send in a new request and cancel the old one to kind of support that new information. What we wanted to do is support RESTful interactions that then allow updates and deletes as necessary. We also wanted to move away from that point-to-point integration. So with HL7 V2, your placer places a request directly with the filler. But as we know from the NGTP, there are a number of organizations that are involved in fulfilling that a genomic test request. And we wanted to support that that whole process without needing to bunny hop between different organizations. And so this central broker and FHIR allows central request orchestration as well as distributed fulfillment of a test request. Additionally, with a genomic test request, obviously you need a lot of clinical history to support interpretation, and these elements are outside your standard OML 021 message. Of course, you can list them all as OBX segments in your HL7 V2, but it's not very well structured as opposed to FHIR, which has concrete resources for different types of information that you want to support. What we have done, though, is provided HL7 V2 to FHIR maps to support anyone who wants to who's still using V2 for their order comms to still interact with the central broker. And this is what we've demonstrated with our alpha with the North Thames GLH. So they have their V2 interfaces with Epic and Epic Beaker, and they uplift it to FHIR to kind of post information into the central broker and downgrade to HL7 V2 again on the outbound. So what have we done so far? So we've published a genomics FHIR implementation guide for the UK, and that's available on the Simplifier website. There's a number of items that we still need to work on. So, for example, aligning with existing other data sets or data collections across the NHS to reduce burden on lab staff. So for example, their monthly submissions to PLCM or disease registration service.
And PLCM is the patient contract laboratory management system, where the laboratories have to submit their activity against different test codes at an individual patient level. So it gives us activity data, but also some other identifiable data.
Then, as NHS England, we also don't have a strategic view of what terminologies to use within genomics. So as we know, there are a number of terminologies within the genomic space for different levels of like your genotypes, your haplotypes, variants, and alleles, and all of that. Within the UK, at least, outside of genomics, NHS England has settled on SNOMED CT being the one on be all system for everything, even though it may not necessarily kind of best represent information such as lab orders and lab observations, for example. But we need to work with the terminology team to ensure that we get a strategic viewpoint on this. We plan, at least in the next few months, to expand the implementation guide to cover those elements of structured reporting, as well as our UGR, Unified Genomic Record, and digital genomic test services work, including provide guidance on how to do that purpose-based access control. So manage access to genomic data based on why you're requesting it, and as well as who you are, and how to represent the test metadata itself. So for a test, what are the targets, what are the methods, and have that information in a standardized format. As queried earlier, we are supporting proactive subscriptions and notifications to genomic events. So for example, when a new test is ordered and it's from a trust that's in your GLH region, getting that information automatically sent out rather than having people have to query the central broker. And expand this requesting reporting framework to other domains within the NHS. So, for example, pathology, radiology, and our national imaging repository. And finally, hopefully, we can make a bit of progress in this next session around comparison of FHIR GRIG, so the Genomics Reporting Implementation Guide, and our own FHIR standards against relevant GA4GH standards such as VERSE and Pedigree. So these are some links for information for those that are interested in terms of where our implementation guide is published, and our API catalog, which serves as the front door for any NHS England APIs. And I think at this point, I'll hand over back to Debbie for the last couple of slides.
Yeah. Second, sorry.
We do questions.
Yes, you can do questions.
At any point.
Yes. I didn't want to break the flow.
I don't know who's monitoring online. Just.
Do you want to go back to a particular slide?
Yes, please.
Which one?
The overall workflow one. Just
That one?
Back a bit more. One more. There we go. Yeah.
That one. Yeah. So just a quick.
Has it showed up again? There we go.
Thanks, Andrew Madison from the University of Melbourne Centre for Cancer Research. The choice of this particular FHIR workflow, there's a gazillion FHIR workflows you can go with. And just had the NHS digital pathology FHIR implementation chosen the same workflow, and if not, how compatible is it with the workflow you've gone with?
So the interesting thing about the pathology implementation is that they were only concerned with reporting. So they hadn't actually done order management at all, which is why we're suggesting that we could potentially expand this into pathology. So they had requests still in HL7 v2 using either old EDIFACT messaging standard or SNOMED codes. And in terms of reporting, they're developing FHIR representation of a report, but they still need to roll that out as well.
And they're going to be much closer on the ground to a V2 world with V2 vendors wanting to do V2.
Yeah.
What has been their response to suggesting going to a more elaborate RESTful based workflow? Or is this a discussion still to happen?
Well, I believe they're struggling is the best word, but I think that there's a push within NHS England as a whole that all new standards should be developed on FHIR rather than using HL7 V2 or V3.
I mean, ordering and resulting with V2 has been in place and infrastructure around it to support error monitoring and management for decades. So it is really a big ask, right, to ask vendors who already have something like V2 set up to replicate ordering and resulting in FHIR, right? And I will argue that there is room potentially for a hybrid solution that combines what we already have in V2 with FHIR for things like requesting more information from the patient record to actually do the interpretation for that test or getting the family history information. I don't think that stuffing all of that information into the order itself is the right move either. I agree with you there.
Yeah, and I think we're actually going to be working soon with HL7 Codex Accelerator for Genomics that have released a data exchange implementation guide, which embeds the FHIR report within a HL7 V2 message, I believe. So that's something that we're going to be looking at as well.
I guess, though, part of this and part of the questions will be, how can we work with you to make sure this becomes functional? And it's not just in England, but what does this mean? And is the direction of travel something that everybody wants? And how do we get to that point? But I think we have to do it together, not separately, and then we get the best outcome for everybody. So,
hi, Augusto, Genomics England. We heard earlier this week about the European health data space changes that are going to force FHIR, SNOMED, and I forget the LOINC in all of this. And so I wonder, across Europe in the next few years, I wonder how much alignment do we have in the UK or England, and with that European health data space, do we have connections? Are we going? Because that would be a really helpful push. I know you made a comment about HL7 Euro, but I think it's beyond that. It's new legislation.
Yeah, so obviously with the UK being out of the EU, we don't necessarily have to follow the EHDS.
I understand
but
that, yeah.
as I think what I'm pushing for within our own interoperability team is that we sign up as a voluntary member, and
Yeah.
there is existing work going on within other areas in NHS England that we share our summary care record in an EHDS-like format.
Oh, that's really cool. Yeah, because if the session is about how we can build a coalition, that sounds like a natural one to start with. Yeah.
Yeah.
Thank you.
How much of this FHIR is specific to UK FHIR standards?
So the UK core is very lightweight. The only thing that UK has done over the base HL7 FHIR spec is bind certain elements to SNOMED CT where they used to be LOINC. So it's very light touch. And so if you've got an international implementation of FHIR, it should still work out of the box with the UK core, as long as you add in SNOMED terms to your codable concepts where appropriate.
Don't move my microwave, but just as a comment on that of, you know, the generalizability of some of the FHIR stuff, there's an ongoing project in Australia around doing a FHIR e-requesting, a general e-requesting, so pathology e-requesting, and the workflow is close to that, but not that workflow. So I feel that's where vendors are going to have difficulty. It's going to be FHIR, but it's going to be they all push pulls, or some push notifies how they go, and that's going to be a nightmare for vendors. I mean, I know they're not just going to support us, like the huge bulk of the NHS is where they're going to put their effort. So maybe in Australia we have to align with this to get any traction. But I'm just saying there is a fair bit of variability on the workflow stuff.
Yeah, well, what I will say though is for the actual payloads for the requesting and reporting, we are looking at the AU e-requesting spec, so making sure there is alignment there. And it's just a matter of where that payload is sent to.
I guess one of the things we want to get out of this morning's discussions is, do we have a contact in each country to try and start to work with? So where we can get to commonality, we can. Where it does need to be different, it is different.
Hi, I'm Lauren Maxwell from University of Glasgow in Heidelberg. So I was going to wait until the end because I've listed sections, but I'm going to just get going. So just I don't think it's on. Okay. So Sue, to your question, I think it's absolutely essential that we have some basic metadata about the implementation decisions that different health data, digital public infrastructures are taking in the health data space. And I think the reasons are obvious, but some of the reasons I'm going to highlight are that we have to know how much work it's going to take for us to bridge these gaps. How much work is it going to take to create this interoperability with EHDS, with ADRC investments. As part of RDA, I've been working with Bob Grossman, that some of you might know, who works in the health data mesh space in the US, to develop a basic metadata survey that we'd like to circulate to folks who are building these health data infrastructures, because we would like to create a living metadata map so that we can share the implementation decisions with the folks who are building their systems, because that's a way to try to get folks to move in a similar direction and to ensure that we don't have so much work on the back end to try to really create this interoperability that we'd really like to work towards. So I'll make a pitch for that, and I'm happy to share the survey that we've developed. And we have a list. So the idea is to create a community of health data commons where we can bring folks together and we can say, look, this is the basic metadata to describe our systems. This is, here's where we have APIs, here's our workflow, here's this conversation we're having. And then folks can learn from one another, and we can try to think, oh, look, you've done that. That's going to save us a lot of money and time if we implement that, as opposed to creating our own bespoke system. So I think we have a real opportunity here because we're at different stages in the implementation cycle. That's one thing. I'm just going to go through this really quickly. I apologize. I've held my questions. So as you're doing your work, I'd like you to think about, how can we demonstrate the value of this? How do we build in the systems that demonstrate the cost, benefits, and harms? And the reason I say that is because NHS England gets a lot of flack, right? So I hear people complaining about NHS England, but from the outside, when Debbie was giving her speech, I was crying inside. I mean, the tears aren't visible, but we're so jealous from the outside. And, I work with Sir Peter Horby and Chris Butler. So the folks who really did a lot of the COVID research. I'm in pandemic preparedness. And you could see in the pandemic how building off of NHS data delivered immediate value for public health globally, not just for, your citizens, but for the rest of us. And I'd just like to highlight, and, I'm crying. I'm also happy for you. I'm sad for myself, but we leave it at that. So I'd like you to think about, how can you build these systems to just display what is the cost savings? And Debbie mentioned in her talk, we think we can build some value off of this. This is transformative R&D value to England. I mean, there's no question you can build just amazing things on top of this data. And I just hold that out there. If you can make that visible to other folks, then maybe, their jealousy would also help them make other implementation decisions. So that's one point I wanted to make. Really quickly, I'd like to just suggest an NHS Data Policy Ambassador program. So you have a lot of learning that you've done over a long period of time, and other folks would really benefit from that. So just, going around to other geographies and helping them, that would be just a very nice thing to invest in terms of foreign policy. And then, other than that, I would like to just hear, what are your thoughts for us in Europe? So I'm sitting in Germany, which is one of the hardest places in Europe to do any work on data reuse. But you can speak to Europe as a whole, so not just to us. What would you recommend in terms of where you see EHS going, and how we could do a better job to kind of get to this idea of what I would call a value-based data strategy. So you have a very clear vision, and you're enacting the vision. And I'm concerned because I just don't see that for us with EHDS. The clarity of the vision and the enactment and the alignment of those two things is not clear to me. And then two other last things. So when you're thinking about describing the value to citizens, I would refer you back to Hans Rossmann. So this and HCR UK does a nice job of this, but I think you could even do a better job of just thinking like, how can we build living metrics on top of this data that show the value, the cost savings in a very kind of transparent and informative way that people like, so policymakers and citizens can play with? Because I think there may be a point where people say, oh, you know, is NHS England, you know, who knows what, because they're in the inside, they're not on the outside, you know, looking in. But I just think that might, you know, save you some time down the line. And then just lastly, so everyone runs into this issue of non-standard variables, right? So we're using the standard, but we can't get people to agree. We have to build our own kind of thing onto the standard, which folks have already alluded to. But I'm just wondering, I mean, so obviously you have like HL7 England, but I'm wondering if you run into that problem even more. So when I was talking to my colleagues at IQVIA about, you know, the problems they have with interoperability, because we have this problem as well. When we get folks to use the standard, 50% of the variables end up being non-standardized because it's very hard to get physicians to agree on any kind of thing. So I'm just wondering if you've run into similar challenges and how you've negotiated that.
Can I just make a start and really thank you for your comments. I think they were really helpful and very insightful, as I would have expected from your presentation on Tuesday. The first thing is what we've been doing, we want to share. So this isn't about, and I think that today's conversation was saying, we've done all this work. It has had to date significant investment, and it will have many, many more millions. It's in the tens of millions we're talking about, as well as the link with all the hundreds of millions that are going into the NHS data and digital developments itself. We don't want to keep this just in the shores of you know, around England. So I think that the bottom question here is really important on how could we all work together on this. I think your comments about value, and at NIF yesterday, Catherine facilitated a discussion all about value and how you demonstrate that, especially for both the investment, not only in the infrastructure, but also in the value of data sharing more broadly beyond individual shores. I think part of what we're trying to build into this is around management information that should be able to give us some of the cost benefit information, but that's still open to be shaped. So I think it's important to, if we work together, to see how we could describe that and have almost a live feed into the value proposition, which is what you're saying. In terms of the more sort of other more technical questions, I'm going to hand over, but I think in general, if from today we can get a list of people who want to join a working group, we're really committed to working and making this something that can be global, not just in England, recognizing there are differences. But if there are general things like the value proposition, the cost benefit, that actually drives us down that data sharing route better than we're doing now, let's try and define it in the systems.
Thanks, Sue. I'm just going to pick up on the on two things. One is the Codex working group, HL7 Codex working group. Literally, we've just had the SOU come back refined so that we're happy to sign it, and it'll be in Sue's inbox, I think, tomorrow. So if you want to join that group as well, there's a technical way of getting your views into a generic development work stream within HL7. the challenges on standards and different clinicians wanting different things in terms of standardization. In the UK, I think we are hugely benefited by a community that is behind what we're trying to do. So whilst there'll be different clinical opinions, sometimes we have really good governance systems that allow us to come to a consensus. And we've got a strong leadership and a strong vision, which people are behind. It's almost a greenfield site. We've got nothing, no walls to break down. We're building. And we've got the power of the community behind us to do so.
I was just going to pick up in terms of the groups, Debbie, and is I wonder, Angela and Justine, with the signature sheet that we were signing, whether we could send it back round to see if we could get an indication of whether people want to be part of a group, because we can do it today and also include those people online. And I think, Catherine, one of the things that would be helpful to know is whether this links with NIF or how you see it functioning within the GA4GH sort of infrastructure too.
I'll make a comment, and I might ask Oliver to comment, is that we did a piece of work a couple of years ago at the request of the government in terms of a national approach to genomics information management. It was quite a detailed piece of work that set up a plan and then a prototype for how we would take that forward. And it's still sitting with government, I think. And I might ask Oliver to comment on that and the intersection with this, because I think the other power is not just, I think we use FHIR standards pretty much anyway in Australia, but how that sort of urging of our government to be doing this, and also benefiting from the interplay, the parallels, the similarities, and the expertise from the UK could be a big driver in our country to help activate it.
Not much to add, but I can try. So the NAGM story, which is what Catherine just described, I feel like it's almost more complementary to some of the things that we're doing here, because it's very heavily focused on the genomic information management and how we represent some of this. Some of the discussions with the HL7 groups on how to represent that information in FHIR came from that, but they haven't been really progressed. And so I think this could really be like a good starting point to reactivate some of those things. Yeah, I'm sure it is. It is like on Andrew's regular discussion list, so we'll see.
Just to come back on that query about kind of standardization and making things implementable, I think we all know that FHIR by design only serves like 80% of your use cases, and even within that, there's variability in how you may kind of populate a FHIR resource. And so I think for us, it's more about learning from the international community, engaging with the international community, and to come to an agreement about how specific elements should be populated for genomics use cases, for example. And that's why we're planning to work with HL7 Clinical Genomics Working Group, Codex, as well as GA4GH to ensure that there's kind of standard representation, not just within the UK, but globally as well.
Thanks, Emma. The power of genomics is in aggregation of data. So that's the purpose. That's what we're trying to do. If we can aggregate it on a global scale, because everybody has got data in the same size and shape, then I think we've won. I'm just going to ask then if has the paper gone round? It's going round again. If people could put their email addresses if they want to be contacted, and then we can ask Catherine about how we set up a working group or within the GA4GH construct. Say again. If you just put a tick, yeah, just put a tick. Okay. So we've got 10 minutes left. Is it worth running through these questions? Is there anything that anybody wants to use this spare time for? Just bit trail for the next session. We've got half an hour now of break and coffee, and the next session is going to be on DRS or DRS. I learned it from reading it, so it's always been DRS to me.
What am I'm just trailing. Yeah. So then the next session. So I'm the token bioinformatician in the group. So the next session we'll get deeper down into how we look at VCFs and so on, and how we link that into this. And I guess like the interface between Omar and I is realized there, and that Omar is the FHIR expert, and I've learned a lot from him of how we can try to get some of this genomic data into clinical systems. And then we've been leaning heavily on GA4GH for how we're going to store, represent, make accessible genomic data. A lot of it is still in development, and it'd be great to get feedback and input on, and also to understand how other people are kind of linking these two surprisingly disparate domains.
I will say as well, even on the order management side, while we've developed like this workflow broker approach and the FHIR implementation guide, these are all still in testing and in beta phases. So if you have any feedback on how things should be adapted, changed, or you see a different approach that's better, then please get in touch.
So I guess people could also sign up to be, to be challengers as we're in these different phases of development as well, not just as part of a community to see how we develop the this globally, but also to help and check and challenge what we're doing. Yeah.
Just following up on that, we have connectathons, which are hackathons essentially. So we can open those up. If you want to come and join us, you can play with the alpha or the beta. Okay, in which case I think we have. Yep.
Just so we get an understanding then, Debbie, do you want to
Quickly run through these questions? Yeah. So has anybody, any other countries adopted FHIR? I heard from Australia is a key yes. Anybody else?
US doesn't speak as a country.
Yeah, that's understood.
But FHIR is heavily used, kind of the norm. I don't hear HL7 featured in conversation. We were late enough to the game.
Yeah, okay. Anybody else?
Singapore. So one of the is that one of the health systems? Yeah.
Okay. For those people who are struggling or who haven't adopted, what are your particular barriers? Anybody got any insight? How much time have you got? Yeah.
Could be long.
All right. Do your top two.
Oh, lack of unreality about the time frames for vendors, not the people not quite understanding like how long it takes for vendors to actually do things, and unrealistic expectations that someone drops a standard by the end of the year. They could, look forward to a small tiny vendor having rolled it out into production within a year or something along the timeline. Not even on their roadmap, and that, this is also all done with no funding, no incentives for vendors to do things. So I think people in Australia are continually surprised, perhaps by the pace at which adoption happens. And I, as a software person, am never surprised that the rate of adoption is incredibly slow because we've given them no incentives, no money, and don't understand how software development works. And what are the other barriers? I mean, standard things in Australia, but it's a very easy one. healthcare system. So it's not a top-down NHS, get the set of strategy and have people agree on that. It's 7 states doing in federal government. It's just a quite difficult landscape to get everyone going in the same direction.
I was at least part that there was some disconnect in your health system, because I've always felt very, very inferior. So it just gave me a little bit of, I was a little bit heartened by that, because I did think we shared some of those issues.
I guess though part of this, and it comes back, I think, yesterday to the end of the NIF session, is we've had to make business or develop business cases to get the level of investment we've got. And I mean, I think as we come out of this, we're talking about probably close to 250 million or so that's gone in pounds.
Half a billion Australian.
And that sort of money that's gone in to the development, as well as everything else that's going in to the NHS itself. But we have to make quite detailed business cases to access that. And I wonder whether a key element of this is also, and I think you were mentioning that around the policy elements of this, is so we could share the business cases or help develop the business cases for people in terms of what's been successful for us.
And a lot of this, the benefits realization of stitching these data together, is in the pharmacogenomic space. £2.2 billion spent on drugs in the NHS every year, and about to go up.
No, we spend, Debbie, we spend £19 billion on drugs. It's the 2.2 that's associated with, essentially medicines misuse.
Sorry, yeah.
As drug reactions or anything else, but we're heading to being over 20 billion in terms of drug. And I still think in cancer, though, if you think about, there are, I think in all of our countries, we've probably got quite challenging priorities for increasing survival. And so by moving to more comprehensive genomic information, linking that with other data, including precision medicine availability or clinical trial access, will actually drive a sea change in survival. So it's those broader, I think, system benefits, and they're different depending on the use case, I think.
So I would just make a pitch for something that you mentioned, which is this, management metadata. So I think we're in a very difficult position where we have to justify these major, so I'm talking about Europe, major investments in this space by success stories. But at the same time, we don't have the metadata to show us where the problems are. So when you have metadata that's agnostic, it could show us harms, it could show us benefits, it could show us cost or cost savings. Then we have a transparent system where we can try to understand what are the bottlenecks. Oh, this works in Germany, but that really failed in France. Like these types of issues. And I think you're in a position to build that because you're a smaller unified system, right? And the numbers that you mentioned in terms of how much you've invested seem quite small to me sitting in Europe, right? Like I think we've put a lot more money into what we're doing. And so my ask would be for you to really talk to folks who run enterprises that are meant to produce a profit, and just say what are the metadata that you embed in your system to understand when you have to make a change, because systems have built these knowledge graphs to try to tell them oh, my airplane arm is going to fall off, or like when they have to make consequential decisions to try to pull that metadata out. And I think you could implement that kind of system and make it transportable so that us sitting in other geographies like Europe could then say, hey, why don't we implement this metadata system? Because I don't think policymakers are in a position to talk about failure, so in a way we need the data to tell its own story and then try to use that as some kind of leverage.
Yeah.
I just thought one thing just one thing that's useful while we're in the room is to ask perhaps Angela, Bob, Oliver, how and where this would best interface in the GA4GH from a work stream perspective, because that's not my realm of expertise, but rather these guys. Yeah.
Failing to a different session after this. I think so. First of all, thank you for this remarkable overview. I've just been trying to soak it all in. It will take me about a week to synthesize everything, and then I'll have a whole bunch of questions for you. I think there's so much here to try to parse out, and I appreciate that you've got these questions up here, but I think to your point here and to Oliver's question, there are questions regarding the clinical workflow, and that is reflected in the architecture. I'm not sure if GA4GH is the right community for that, but you've mentioned others and some accelerators and some things where that could take place. And I think it'll be critical to have the software vendors in those conversations, because a lot of that architecture and those workflows reflect the internal communications between those systems, as you know. External to those workflows, when we're talking about data representation, I think that's where we can start partitioning between an HL7-like community where those data structures might be maintained as natural native EHR type records, or something that would pertain to GA4GH. And where those two things come together, which is your second to the bottom point here, I think there's potentially a lot of interest, certainly from my group, in that space. And maybe, Oliver, that's where we can start focusing, is on the data structures that would be genomic in nature, but reflected by clinical testing, the metadata around that, the interpretations that would be relevant to GA4GH, and look at that intersection in the translational space between GA4GH knowledge graph that would extend into clinical practice. Oliver?
No, yeah, completely agree. And like particularly the information flow between those. Like, yeah. So I think that's probably the start point. Sorry, Angela, you had your hands up first.
To go, but I think rather than a work stream or a study group, it seems like this more feels like a GIF project, Mallory, like looking at not just how GA4GH standards work together in a real world context, but also in a first ever GIF project looking at other standards pulling in.
That's it.
This is first. We need to go.
Today in just practical terms was like initially just getting, like I said, like spend a week or two, get a sense of the ask and the shape of this whole thing, bring a couple of people in, so because we don't want to be gatekeeping. And so then the question, what does that look like? Does it sit in GIF? Is that a community of interest or something else? And then expand from there. And just same what you just said, we only have a small fraction of people here in the room. So who else is interested in this and can feel different components? But
Okay.
I need a bit more time to map that.
That's
I
great.
think.
Thank you so much for everybody's input, and really looking forward to working with you, hopefully to everybody's benefit.